Silvio IMF I'm director of the Medical Imaging Hub. Good afternoon to everybody, and thank you for attending today Euro-BioImaging Pub meeting. Today our talk will be devoted to Theranostic, a very important emerging field that merge imaging and therapy, making imaging even more central in combating the most relevant diseases. We thank Professor Twan Lammers, who is definitely an authority in the field of drug delivery and Theranostics, for having accepted our invitation to deliver his lecture today. Twan is working at the Institute for Experimental Molecular Medicine, Department of Nanomedicine and Theranostic at the Aachen University Clinics. Twan obtained a DC in Radiation Oncology from Heidelberg University in 2008 and a PhD in Pharmaceutics from Utrecht University in 2009. In 2014, was promoted to full professor in medicine at Aachen. His research is always focused in improving disease treatment by combining drug targeting and imaging. Twan has an excellent publication record with an H index of 67, which is quite remarkable for his age. Many awards, like the Starting and Consolidator ERC grants, the Young Investigator Award of the Controlled Release Society, the Aldrich Delft International Award, and the one award from the Belgian Society for Pharmaceutical Science. He served in several editorial boards, and it is the handling editor for Journal Controlled Release, Drug Delivery and Translational Research, and Molecular Imaging Biology. It is a pleasure for me today to introduce Twan lecture. Twan is, I would say, an old friend of ours. We interacted many years ago through a European program in the 7 European program at that time. The title of his talk is Theranostic Nanomedicine. Please, Twan, the floor is yours.
Thank you, Silvio. We go even more back than FP7. It was FP6 when we started working on that, so it's already that long. It's a great pleasure for me to be here. Looking forward to a good discussion, so I can skip a bunch of slides at the end. If you feel that you have a question to one of the slides, just unmute yourself and say, I have a question regarding this. I think that makes the discussion much more vibrant. And I think it's especially the discussion that is important, right? So what I would like to discuss with you today is Theranostics. Theranostics mostly from the field of drug delivery and drug targeting, nanomedicine. I'll also give a couple of general, let's say, applications of Theranostics, or what I think are really classical applications of how you can use imaging to better guide therapy, to find the right patients, to monitor actually the efficacy of the treatment. And as something of a subtitle, it was actually a title that I initially submitted, I would like to discuss some strategies with you, which I consider smart. People use smart a lot in chemistry for activatable probes, for light irradiation. Some of these technologies I think are very art-like. It's really intuitive or ingenious to see what you can engineer at the nanoscale. But if we think about translation, I think then smart gets a completely different meaning. And then smart oftentimes means simple or realistic. And I think in simple and smart strategies forward in cancer nanomedicine, imaging can play a big role. And that is what I would like to discuss with you today. Good. So for those of you that might not have followed the nanomedicine field in the last couple of decades, I think the term was first coined in 1999 in this book by Freitas. And what nanomedicine is by definition is the application of nanotechnology in medicine. And this is broad, right? It's not only drug delivery. Drug delivery is oftentimes perceived the holy grail. So that is what everybody thinks nanomedicine is about. But it's actually much more. It's also the etching of surfaces to do very sensitive detection, or the engineering of gold nanoparticles that recognize proteins or nucleic acids in urine or in sputum, right? Or in other types of ex vivo tissues. So by definition, nanomedicine is much more than drug delivery, but drug delivery is actually what most people do with nanomedicine. Probably around 90% of nanomedicine is related to drug delivery. And we use nano in drug delivery because if we think about cancer therapy, and this applies to a number of other therapies as well, drugs that are either orally administered or intravenously applied, they have a lot of difficulties in reaching sufficiently high concentrations at the pathological site. So if we now take a classical drug, doxorubicin, most of you will have heard of this drug. It's very extensively used. I think half of the explanations for why it's so extensively used is because it's fluorescent. So many people use it because of its fluorescence. But I think it's a very potent drug. It works really well in many different types of cancers. But it has a couple of clear side effects that limit its use. And one of the most prominent ones is this distribution pattern that you see here. So if we take doxorubicin, we administer it intravenously in mice, but in patients, the situation looks the same. We get very high concentrations in healthy tissues and low concentrations at the pathological site. And particularly this concentration in the heart is problematic. So this is a first pass effect when you intravenously infuse. Doxorubicin has so-called vesicant properties. It immediately extravasates within the heart tissue, and it damages the cardiomyocytes, so the beating heart muscle cells. And because of that, you can only give doxorubicin 6 times. You have to stop afterwards, even if the patient is responding very well, even if he or she is on track to maybe a complete cure. Clinicians will never give doxorubicin more than 6 times, because otherwise the cumulative heart damage will be too high to not cause any risk to the patient. So this biodistribution pattern is a problem. And that's why we have been using carrier materials, nanomedicine formulations, for many different years. If you summarize what nanomedicine are, I'm not going into the details here, but I think it can be summarized in 2 sentences. On the one side, nanomedicine protect the drug from the body. So they prevent the drug from being excreted via the kidney very fast or being degraded in the liver. And at the same time, or vice versa, nanomedicine actually protect the body from the drug. So they prevent the drug from going to sites where you do not want to have it, like the heart in the case of doxorubicin. And that is actually also one of the main reasons why doxorubicin nanoparticles, doxorubicin liposomes, which are very prominent nanoparticles, are actually on the market and a very successful clinical product, because they strongly avoid accumulation in heart tissue. So I'm not going into the details of the schematic here, which we drew a couple of years ago. I think there are many different types of nanoparticles that are used. Some of them are more clinically relevant than others. Particularly the ones on the left, I think, are clinically used and have already been translated: polymers, mice cells, antibody conjugates. If we think about strategies, the main strategy that nanoparticles use is so-called passive drug targeting. That is based on the EPR effect that I will introduce to you in the next couple of slides. But you can also do active targeting, right? So you can modify the surface of a liposome with an antibody, or you can modify a mice cell with a peptide to improve the interaction of the nanoparticles with cancer cells. And this mostly helps to enhance internalization. It doesn't really improve tumor accumulation very much, but you can really deliver your cargo into the target cell. You can do the same thing with endothelial cells. And we can also engineer nanoparticles to be responsive to triggers, for instance, to heat. So you can preheat a tumor with ultrasound or radiofrequency ablation. You can do that even under imaging guidance with MRI. You heat the tumor to 40 degrees, and then if you engineer a liposome that responds to this slight increase in heat, you can ensure that you get efficient local drug release only in the preheated sites. And also this is really on the way to become clinical practice. There are a couple of these products in phase 2 and phase 3 clinical trials at the moment. Okay, so back to the basics. EPR effect. EPR effect is based on a long circulation time. And via this long circulation time, you use vascular leakiness and the lack of lymphatic drainage in tumors, and also actually the presence of phagocytes in tumors, macrophages, to enhance targeting. The first nanomedicine product that was developed is this formulation here, Doxil, doxorubicin in liposomes, pegylated liposomes, developed by these people here, Gezi Bagenholz and Alberto Gabizon. And in the first clinical trial that they did with this formulation, they showed that if you entrap the drug in a liposome, you completely change its pharmacokinetic pattern. So instead of the drug being excreted from the bloodstream almost instantaneously, right? So while you infuse it with a half-life time of 5 to 10 minutes, it's actually disappearing from the bloodstream. And once it's gone from the bloodstream, it cannot accumulate in the tumor anymore. So if you then take liposomes, you load them with doxorubicin, you can keep them in the bloodstream very, very efficiently. So liposomes have a circulation time of 2 to 3 days, half-life time. So even after 1 or 2 weeks, you still have good amounts of liposomes in the circulation of patients that can, via the EPR effect, target tumors. So all of this holds true and is efficient if we have tumors that are very positive for EPR features. And those include a lot of blood vessels, obviously, and a lot of leaky blood vessels. And one of the prototypic cancers that shows this pattern is a disease called Kaposi sarcoma. That's what you see here. And this is a first in-weight theranostic scan in which you have doxorubicin liposomes labeled with a radioactive agent. So you can monitor the biodistribution and the circulation behavior of liposomal doxorubicin. This patient has AIDS-related Kaposi sarcoma, that's what I already said. So they typically have metastatic lesions and primary tumors. The primary tumor is here in the lower left leg. Multiple metastases in the same leg. These are metastases in the head and the shoulder region, the facial region of the patient. And these two other hotspots that you see here, that's the spleen and this is the liver. And those organs also accumulate nanoparticles because these organs display features that are similar to the EPR effect. So they have a lot of blood vessels, they have an open vascular system, they have fenestrae, and they also have a lot of phagocytes, so Kupffer cells and splenic phagocytes, to take up the nanoparticles and retain them within the organ. So if we have a tumor that has EPR features, we can target efficiently and we can substantially enhance efficacy. That has been known for already 20 years. And here the key example, as said before, Kaposi sarcoma, the key phase 3 clinical trial here was a comparison of Doxil, so only the liposome with doxorubicin, versus 3 chemotherapeutic drugs given together, adriamycin, which is doxorubicin, but the trade name, together with bleomycin and vincristine. These 3 classical chemotherapeutic agents together in Kaposi sarcoma caused approximately 25% partial responses. And if you only give Doxil, only liposomes with doxorubicin, you get 1 complete response and almost 50% of partial responses. So you double the efficacy of the treatment, and at the same time, you reduce toxicity. These patients have no issues with cardiomyopathy. The accumulation of liposomes in the heart is close to 0. So you can also give it as many times as you want. And patients also perceive the treatment much better. They don't lose hair, they feel less nauseous, they don't have any sleeping and eating problems, and so on. So it really improves both ends of the therapeutic index, both efficacy and toxicity. So far so good, I would say, but then, more realistic, or one slide in between, this is an overview of products that we have currently on the market. Many different types of products based on protein drug nanoparticles, Abraxane, which is carrying paclitaxel, Doxil, which we already discussed. There are polymer protein conjugates with asparaginase proteins conjugated to a polymer. There are nanoparticle formulations of a lipid drug. There are liposomes recently with irinotecan, very potent drug used in pancreatic cancer, but patients do not tolerate it. They feel very sick and they actually do not want the clinicians to give it to them. But if you put irinotecan in the liposome, the acceptance of the patient is much better and much higher. I think one of the coolest ones is actually Vyxeos. That's a liposome that contains 2 drugs in a fixed ratio. So it's always 5-to-1 ratio of cytarabine to daunorubicin. And this is really inducing unprecedented responses in patients with refractory acute myeloid leukemia. So these patients do not respond to any type of standard therapy anymore. But then you come with a liposome that contains 2 drugs in a fixed ratio, and then you curatively treat, so you completely treat over 30% of these patients. I think that is pretty spectacular. Good, so the downside, this is what I already alluded to before, is that we gradually started realizing that this effect that people have called for, I think, 35 years now, the enhanced permeability and retention effect, that is actually quite variable, right? So there is a lot of difference in tumor accumulation based on the so-called EPR effect between patients and mouse models, between multiple lesions within one patient. So this Kaposi sarcoma patient, there are multiple metastases here in this shoulder region of the patient, and you clearly see that there are striking differences in the extent of accumulation, right? And even within species, these are sarcomas in humans. There we know that sarcomas accumulate quite well. This is a soft tissue sarcoma of a hand. This is a healthy hand, so clear accumulation. This is a huge soft tissue sarcoma in a Labrador dog, so it's a real patient, but a dog. And what is actually observed in Labradors is that sarcomas accumulate very poorly. So it's the opposite. It's the same cancer in a different species, but we have a different EPR profile, right? And that in a way urges us to consider approaches to address this variability. And one of them is imaging, as you'll learn in the remainder of this talk. I would like to talk you through this table first, because there has been a lot of, I would say, dispute or rumor in the last couple of years, claiming that the EPR effect does not exist in patients, right? Whether permeability and retention via leaky vessels and absent lymphatics, whether that are the most important physiological processes, I'm not sure, right? You might even argue that lacking lymphatics is much less important than phagocyte presence within the tumors. But that aside, so let's use EPR from the perception of tumor accumulation. Even then, there are a lot of people saying that EPR or tumor accumulation does not happen in patients, right? That's nonsense. So if you look at this table, these are data, very old data already, very systematically done by Harrington and colleagues. They used whole body gamma scintigraphy and SPECT to visualize and quantify tumor accumulation of liposomes. And what you see is that out of the 17 patients they included, there were only 2 that were negative, right? Whether positive means super good accumulation, right? That's obviously not the case, because you see the numbers here and here. They vary from 2% to up to 50% of the injected dose per kilogram tumor, right? There's a lot of variability, but in 15 out of 17 patients, nanoparticles did reach the tumor. So it's really nonsense to say that tumors cannot be reached. It's just variable, and we need approaches, we need strategies to actually enhance responses to address this variability. And I think among the most obvious things here is that we use strategies like imaging to do personalization, to evaluate which patients have good accumulation, which patients have poor accumulation, those should be excluded in clinical trials. Which patients have good accumulation, those should be included in clinical trials. And in addition, we can also think of concepts like pharmacological priming or physical priming to enhance accumulation either locally within the tumor or also at the systematic or the systemic level in metastasis. So back to the word smart. A couple of years ago, we sat together and tried to figure out what strategies can we really implement to advance and refine treatments, right? So very realistic, very simplistic. How can we enable patient stratification in nanomedicine? And it's important here to realize that this is not being done. And I think it's remarkable. It's actually, it's probably even stupid, because all new oncology drugs that make it to the market, especially those coming from big pharma, they have already biomarkers associated with their use, associated with patient stratification from the late stage preclinical phase onwards. And in nanomedicine, we're actually giving the drugs to every patient. We're not putting any effort in selecting patients that might or may not, for instance, display the EPR effect. So I think this is really something that we need to tackle. So let's first look at patient stratification. And that puts me to the title word, Theranostics. Theranostics is the intimate combination of diagnosis and therapy. You could argue that it should have been called Therapeutics or something like that, because diagnosis always comes first. Well, the term was Theranostics, and without the term being used, I think this intimate combination of diagnosis and therapy involving imaging has been done for many, many years, right? This is a pretty old image from a German study in a patient with thyroid cancer, in which you use just the iodine molecule, so just iodine-131 as the classical theranostic compound, right? So the molecule is visualizable with gamma scintigraphy, also with SPECT, and the molecule is also an internal radiotherapy emitting agent. So you can, in a way, irradiate or radiotherapy treat tumors from the inside. So what you can then do is you can first inject a very low dose of this agent in a diagnostic setting to see in a patient with thyroid cancer whether there is strong accumulation within the thyroid, whether you can also delineate the structures that have been identified with other techniques as being the thyroid tumor. And that is clearly the case in this patient. Then you up the dose, so you give much higher levels to do internal radiotherapy. That's why you also start seeing bladder clearance here. And then you actually see that you get accumulation at the pathological site, and over time you see the tumor disappearing. So you can do with one and the same theranostic molecule, you can do diagnosis, treatment, and treatment monitoring. There are a couple of similar examples. Those are typically not, single molecule theranostics like iodine, but they're so-called theranostic pairs in which you use peptide molecules. The first and most famous one is probably DOTATOC or DOTATATA, which targets so-called somatostatin receptor positive tumors, neuroendocrine tumors in most of the cases. And the setting here is that you initially take a diagnostic radionuclide, like indium, and then this is called a so-called octrio scan. This is done pre-therapy. And when you use indium, the patient does not have any radiotherapy from the inside. So there is no, damage causing beta emission from indium in this patient. This scan is done purely for diagnosis. This patient had a pancreatic tumor with multiple liver metastases. You see that the primary tumor and also the metastases are targeted with this peptide construct. That means this patient should be included in a clinical trial or should be treated with this probe. Then you switch to lutetium-177, which is a very strong internal radiotherapy agent. And then you can actually start doing treatment. And obviously you can also image lutetium, right? So then you can do treatment and treatment monitoring at the same time. And you see over time how the disease disappears with this theranostic pair. And you actually only initially do this first step with indium to ensure that patients that do not express this somatostatin receptor are not unnecessarily exposed to internal radiotherapy with this lutetium-containing probe, which does to some extent also cause some damage to, for instance, kidney function. Two other examples from the nuclear medicine field. I think this one is actually another DOTA-TOC example. So again, somatostatin receptor targeting. This is just to show you the potential on the one side of this treatment. If you have neuroendocrine tumors, they tend to be very radiosensitive. This is before peptide receptor targeted radiotherapy with a gallium DOTA-TOC, many metastases, as you can see. This is 3 cycles of yttrium DOTA-TATA treatment, and essentially all of the tumors are gone, except for one, which we can now trace because of the imaging we're doing. So also from a theranostic point of view, this is very helpful because now we could actually start doing, or at least start considering doing surgery on this one lesion, which I think in the initial case, it's obvious that surgery doesn't make any sense. Here, there's only one lesion remaining, right? All of these points are from the kidney, and all the rest seems to be clear of cancer now. And the imaging information tells us that this patient now is almost clean of cancer. 2 other approaches before we go back to nano. So very prominent in the last 10 years, I think, have been peptides or small molecules or even antibodies that target the so-called PSMA, the prostate-specific membrane antigen receptor, which is expressed in prostate cancer, obviously, prostate cancer metastasis, also on the endothelium of other types of tumors, but not so extensively. And what you can then do is in a way the same, right? You do first, before you do therapy, you start with a gallium. Gallium is purely diagnostic. It does not do internal radiotherapy. You use, in this case, the PSMA-11 construct. You see accumulation in multiple organs, kidney, liver. These are other what are they called? They're glands, so they're salivary glands, which actually also cause quite some side effects. You can monitor salivary gland accumulation already or predict it based on the diagnostic scan too. By far most important, obviously, is this diffuse localization here, which is primary prostate cancer tumor and metastases, right? And then you can do this with PET-CT as well, so then you get much more spatial information. You can make it 3D instead of 2D, and you switch again to lutetium-177, and you see how all of these primary and metastatic prostate cancer lesions are disappearing. And then I think the biggest or the most remarkable achievement in the last couple of years, like really the last 2 or 3 years in nuclear medicine field, has been made by a probe that is called FAPI. It's the fibroblast activation protein. To the best of my knowledge, there are no conclusive clinical studies yet on doing this theranostically, so to really see treatment outcomes. But the people around Uwe Haberkorn and colleagues in Heidelberg, they've already shown that using this fibroblast activation protein probe, you can monitor tons of metastases very specifically in patients with many different types of cancers, right? These are 12 different types of cancers. And just because of the cleanliness of the signal, right? This really shows the potential of this probe for doing tumor detection and probably also targeted tumor treatment. So the only unspecific thing you see every now and then is some kidney signal and some bladder signal. All the other signals here are cancerous lesions that are visualized and in the future potentially also treated with this theranostic peptide probe. So with nano, we can do the same. And this is what Silvio was referring to. So we were in a European project that ran, I think, from 2006 to 2010. That were the early days when Theranostics was coming up, the early days when nanomedicine was coming up. And we, in this European project, we actually had a very strong diagnostic group of people, a very strong therapeutic targeting group of people, and we brought them together. And we did a lot of cool, I think, pioneering science, which also resulted in a couple of products that are still in clinical trials. I will come back to that at the end. And we wrote also a perspective on how you can use Theranostics in nanomedicine and how you can use imaging to do drug delivery evaluation, to do assessment of drug release, for instance, trigger drug release with hyperthermia, and also how you can use imaging to do drug efficacy monitoring in different types of settings. What I think is the most important take home from that perspective is that we can use, like I showed you for the nuclear medicine probes, we can use information on the efficacy of tumor targeting to predict nanotherapy outcome, right? And that is the basis for doing patient stratification. And that is a big lack at the moment in the field of nanomedicine cancer therapy. So what we've known from the clinic, and this is what we discussed already in Kaposi sarcoma, liposomes radio-labeled with doxorubicin, they show high EPR, strong accumulation in tumors and metastasis, and they also show high efficacy. So more than twice as effective, much less toxic, better tolerable. In this patient population with good accumulation, Doxil works. Vice versa in breast cancer, many different types of breast cancer, so we should be careful not to generalize. But in certain types of cancers, what you see is large primary tumors within the breast of patients, multiple centimeters, which show much less accumulation than much smaller metastatic lymph nodes. Right? And that shows that the primary breast tumor is quite difficult to target based on vascular leakiness, for instance, or tissue penetration, because breast tumors tend to be very stromal. So they have a lot of collagen content, they have a high so-called fluid pressure within tumors, and that makes it difficult for liposomes and other nanoparticles, and also for antibodies to actually properly accumulate and penetrate into these lesions. And with imaging, we can actually capture that. And we could only include those patients in which we at least see that some of the targeted probe makes it into the tumor, right? And that will help in translation, because if we blindly give it to 100 patients and 60% of the patients, so 60 patients as a total also do not show any accumulation, then the drug will not work. And that will really ruin your statistics. And if you do enrichment, you only include those 40 patients that show good accumulation, then it's much more likely that the treatment can actually work. So let me show you some data from clinical trials. This was one of the earliest studies done theranostically with a nanomaterial. This is from the group of Len Seymour in Oxford. They worked with an HPMA probe, which was targeted to the liver using galactosamine. It's expressed by hepatocytes, and it was assumed to be also expressed by hepatocellular carcinomas. And what they showed is that when you in patients monitor the polymer with doxorubicin with or without the sugar, you get some level of tumor accumulation, but overall quite rapid clearance. And if you add the sugar, you actually see very, very strong liver localization. And that was initially perceived as being very promising. However, if you look much more carefully into the liver tissue itself, you see on the right here, this is an anatomical CT image where the tumor mass is central. Healthy liver is surrounding the tumor mass. And where the probe goes is actually to the healthy parts of the liver. So it doesn't target the cancerous mass that is present within the middle part of the liver. So you could, in a way, already have predicted that this probe would not work. And that was the outcome, right? If they would have done this imaging systematically, they only did it in 2 or 3 patients just to prove the principle of targeting. If they would have done it in all patients and excluded patients that look like this patient, then maybe it would have worked in a fraction of patients. And then maybe this would have been a clinical product now, right? That was not the case, and that's arguably one of the reasons why this failed. I think there are 2 smart approaches that were recently published by a company in the US called Merrimack Pharmaceuticals. The most smartest was probably the most simple one, the most straightforward one. They use an iron oxide nanoparticle, which is called ferraheme. This was initially developed as an MRI contrast agent, but it turned out to be not superior to other MRI contrast agents or protocols. So it was marketed eventually as a drug for acute anemia in patients with kidney disorders. But obviously you can use this drug also as an imaging agent, right? It is an iron oxide MRI contrast agent. And it is also a nanoparticle that if tumors have EPR, they will be able to accumulate in tumors via the EPR effect. They do not circulate as long as liposomes, but that in a way does not really harm in the assessment of whether tumors are targetable or not. And that is exactly what Merrimack did. So they went to a large number of patients with different types of tumors. They had a cohort in which you show high accumulation. So this is nanoparticle concentration. Each of these points is a different patient. You have patients with good accumulation, high EPR, high nanoparticle in tumor, and low EPR, low nanoparticle content. And if you then look at the patients that are above the median, that are good EPR accumulators.
Hallo, Volker.
Sorry?
Yeah.
Okay, I heard a voice, but that was not a question. Anyways, so I was saying that when you use these iron oxide nanoparticles to stratify tumors, those patients that show good uptake of the iron oxide nanoparticle, they also respond well to treatment with a therapeutic nanoparticle. And Merrimack has developed Onivyde, so the liposome with irinotecan, and they use here this iron oxide as a companion diagnostic to monitor how well you can predict Onivyde therapy. And that seems to be the case, right? So on average, these tumors shrank during treatment with Onivyde, and that can be explained on the basis of accessibility via imageable EPR effect. Vice versa, patients that do not accumulate a lot, on average, tumors kept on growing. And these patients were obviously candidates that in a clinical trial with therapeutic intent should have been excluded, right? Because some of them might have responded, but if you would take out these 50% of patients, then overall the outcome and the statistics of your clinical product would have been much better, simply by enriching for patients that are more likely to respond. And that is what Theranostics and imaging can bring us. Second example from the same company, published in the same issue of Clinical Cancer Research. So this is where they did it classically theranostically. So they took a liposome that was HER2 targeted. That doesn't matter in this context, but it explains why all of this was done in breast cancer. So it's patient with metastatic breast cancer, primary lesions, and all sorts of metastases, lung and bone and brain. They labeled the dox liposomes with copper-64, and they monitored them over time while they were administered to patients. And then using positron emission tomography, you can accurately quantify the percent of the injected dose per tissue. And then they did exactly the same thing. So they had a cohort of patients with low uptake and a cohort with high uptake in the tumor. Those patients with high uptake on average responded quite well in terms of progression-free survival time, and those with low uptake on average did not respond very well. So bottom line of this is imaging can be used for patient stratification. Imaging probe accumulation correlates with therapeutic outcome. And overall conclusion to me, we need to figure out how we can use such concepts to do patient stratification. Keyword now is, should we actually use imaging? I think imaging is very useful, very elegant, but it's not very straightforward. It can be quite costly. It needs very dedicated equipment. It needs local experts, right? Many community hospitals in not so big cities might not have PET-CT or advanced MRI equipment. In theranostic cases, you need dedicated radiochemistry labs that actually on the spot label your probes. So imaging is, in terms of if you compare simplicity versus specificity, theranostic imaging with radionuclide labeled probe is definitely the most specific way of following your nanoparticle and doing patient stratification. But it's also the least simple one because of all the conditions that you need to adhere to in terms of availability of expertise and equipment. What's already in a way easier is companion diagnostics, because there you do not need at least the radiochemistry equipment. But one could argue that we can actually maybe use standard imaging equipment and already approved clinical contrast agents like gadolinium probes or like microbubbles for ultrasound to image aspects of the drug delivery process that also help us to say yes or no patients should be included in clinical trials or should not be included in clinical trials. And we published a very simple, straightforward, I would say, paper in the, I think 5-6 years ago, 2014 already, just demonstrating that if you use highly available ultrasound, which is probably available in any, community hospital, and more than one device likely even, what you could do is you could image perfusion of tumors. So you can image how well blood flow in tumors is actually taking place. And what we saw is that when we image perfusion, if you look at the bottom panels, these are CT26 tumors before and after the administration of microbubbles, which are ultrasound contrast agents. This tumor does not have a lot of perfusion because in the tumor, you only see a couple of these color-coded spots. This is intermediate perfusion. This is high perfusion. In those tumors in which we have high perfusion, we have high targeting of, in this case, polymeric nanoparticles. And in line with that, in those tumors that have poor perfusion, we have low uptake. Right, so that's a reasonably good correlation, 0.8 or so. It's not fantastic, but it's probably good enough to say yes, patient should be included, or no patient should not be included. Because if there is no perfusion, or if there is very poor perfusion, it's unlikely that patients will be responding. So if we take a couple of steps back, so maybe what would have been even easier is if we could predict patient response and do patient stratification on the basis of tissue biomarkers. And this is how it's done for the vast majority of other targeted drugs in the clinic, right? So if you give Herceptin therapeutic antibody, what is typically done is you take a biopsy of the tumor, you stain for the HER2 receptor. If the expression level of the HER2 receptor is very high or high, then you give the drug. If it's low or absent, you don't give the drug. And by doing that, you can ensure that Herceptin is actually functional in those patients to which you give the drug. And actually, without that type of stratification, Herceptin failed in clinical trials. So it was actually shown that you need to enrich for patients that express medium to high levels of HER2 in order to make Herceptin better than standard chemotherapy. And just to give you a feeling for how those percentages are, so it was only less than 20% of patients that were in the end included in such clinical trials. So you take out 80% of patients on the basis of biomarker selection, right? In this case, biopsies. In the case of imaging, it would be just imaging-based tumor accumulation. 80% of patients is out, but in the remaining 20% of patients, your drug is very likely to work. So you simply need to integrate such protocols into translational research to bring your product to the market. So what we needed to make this a lot easier is to try to figure out whether we can stain certain features in tumors that can help us to do patient stratification. So we looked at a bunch of different features like macrophages and vessels and collagens and cellularity, just nuclear density, lymph vessels, types of collagens, and so on, in multiple different tumor models to figure out which of these features contributes the most to efficient tumor accumulation. And we initially did that in 3 different tumor models just to characterize all the different features. A431 with low tumor accumulation, MLS with intermediate, and CT26 with high tumor accumulation of nanoparticles. And we observed, and these are the two exemplary examples of features that correlate quite well. And they're actually also obvious, right? You need blood vessels to get your nanoparticle to the tumor and into the tumor. So the more blood vessels we have, the better tumor accumulation is. And vice versa, we need macrophages in the tumor to keep the nanoparticles that are extravasated out of the blood vessels, to keep them within the tumor tissue. And in certain cases, like liposomes, also to process them, to actually get the drug out of the liposomes. And we see a really good correlation between the amount of macrophages and the accumulation of nanoparticles within tumors. So maybe by smart combinations of 2 or 3 of those features, we can eventually find a way to do patient stratification simply via biopsy, which, at least if you work in patients with a not very high number of metastases, allows you to do good, decent patient stratification. Because if we have patients which are which have metastatic disease, and those are the majority in clinical trials. So patients in phase 1, phase 2 trials, they typically have metastatic disease. They already had like 5 to 6 other treatments which do not work anymore, right? So it's very difficult to actually achieve good responses in those patients. But the bottom line here is that if you have more than 1 lesion, then actually the variability in tumor targeting in all cancers throughout the body goes up logarithmically. Right? So we need approaches like imaging. Then we actually need imaging again because the biopsy from the primary tumor will not tell us something about the metastases. So then we're back to the beginning. Then we need imaging to do patient stratification. So we've been exploring this together with a company in Maastricht in the Netherlands. It's called Crystal Therapeutics. This is a company that spun off from this European project that Silvio and I were involved in, Meditrans. It's a technology that is based on core cross-linked polymeric micelles. So it's a polymeric block-copolymer self-assembly that is then cross-linked with chemical linkers to which drug molecules are attached via a cleavable linker. So it's a fully stabilized system that circulates for up to 30 hours half-life time in patients. So it really works well. And we've been showing together with Christiane that we can actually target metastatic lesions in mice, and I'll show you later on also in patients. We've done this using multispectral optical imaging, so we can label the cancer cells with a dye that is excited at a 680 laser. So we see the tumor, we see metastasis in this lymph node. You see the large lymph node here. We see diffuse metastasis in the lungs, like in the images here in the bottom. And when we then label the mice cells with another tracer, with another near-infrared agent, we can actually monitor how well we can target these lesions. So you see a lot of accumulation in all of those lesions that I just described, the primary tumor, lymph node, lung area, and this difference here, that's again the liver, right? So beyond the cancerous sites, we also see accumulation of the micelles in the liver. We also showed that we can inhibit metastatic formation and do metastatic treatment with these so-called CRYPAC products. And in a multi-year effort, we actually set out to transfer what I said before to the clinic. So to go to a strategy in which we can take these micelles, functionalize them in such a way that we can monitor their biodistribution. So we can label them with a long-lived radioisotope, zirconium-89. And based on these zirconium pictures of the, the circulation time and the accumulation in tumors and metastasis, we would then eventually be able to do Bayesian stratification. Two examples here on the right. So in FDG, you see the tumor. This is glucose metabolism, imaged in the tumor, imaged by positron emission tomography. CT is for anatomical reference. And on the right, you see the accumulation of the micelles in this tumorous mass based on zirconium imaging. This is a facial tumor. It's a metastasis from a myeloepithelioma, which has a spotty accumulation that is not very high, but there is a reasonable amount of accumulation. This is a very nice example, 2 lung metastases coming from colorectal cancer, where you see very strong and quite homogeneous accumulation of the micelles within those 2 metastases. And what we're trying to do here is actually to systematically analyze micelle targeting in metastasis in patients. So in the first 5 patients, we're currently writing up the manuscript and we have a couple more patients, but in the first 5 patients, we had 100 metastases in total. We set the criteria for targeting to be metastases that are larger than 2 centimeters. And of those, we had 46. And in those 5 patients with 46 metastases, we then evaluated how many of those metastases we could target. And that turned out to be 16. Right? So 16 of the 46 metastases, 35%, were targetable via EPR-mediated micelle targeting. I think the number is not bad. It's probably also not fantastic. But the point here is that this strategy as such allows us to really go towards saying this patient has 2 metastases. Both metastases are positive for uptake. This patient needs to be included. And this patient here, esophageal cancer, 12 metastases, none of them show uptake. This patient should be excluded. Right? Don't know how to handle these cases, right? Where you approximately have half of them targeted, the other half not. That'll be matter for debate later on. But I think the principle is shown based on this quite pioneering study. Last 2 to 3 minutes, I'll like to share another platform with you. We call this platform PiCells. So they're similar types of polymeric micelles, also based on a backbone of polyethylene glycol and hydroxypropyl methacrylamide. But in this case, we cross-link the micelles not chemically with a cross-linker, but via covalent or via hydrophobic interactions, so-called pi-pi stacking. That's why we call them PiCells. So they have aromatic groups within the hydrophobic core of the micelles. These pi electrons, they stabilize the micelles in the circulation, and they also enable stable and efficient loading with aromatic group containing drug molecules, such as taxanes and other types of anti-cancer drugs. We've shown that these PiCells perform quite well. If we load them with paclitaxel, we see substantial enhancement of circulation time as compared to the free drug in mice. We can completely cure certain mouse models. So these were 2 different, it was a breast cancer model and a skin cancer model. Both models, we could completely suppress tumor growth, partially because we could go to much higher doses. So if you take the free drug, Taxol, you can see that there is some tumor growth inhibition in terms of a delay of tumor growth, but there is no complete cure. If we take an equidose, so the same dose of the micelles, we can almost completely stop tumor growth. And if we take the micelles at a double dose, which as you see here, does not cause any difference in body weight, so it's not more toxic, then we can completely suppress tumor growth. We've confirmed this in a follow-up study with another drug. So then we took docetaxel. Docetaxel is used extensively in lung and gastrointestinal cancers, among others. We did this in collaborations with clinicians from China. They have a huge interest to better treat gastrointestinal tumors. So that includes everything from gastric, esophageal to colon and colorectal, right? There is a very high incidence in these GI cancers in China. And when we take micelles and compare it to the clinical drug, so we compare it to Taxotere, which is free DTX, in all models that we tested, it's a cell line-derived, a patient-derived xenograft, IP metastasis, lung metastasis. In all situations, we can actually get substantially enhanced efficacy of these PiCells as compared to the clinical product. With these SPI cells, via one of the ERC proof of concept grants, we're trying to push this forward towards patient stratification. This is very much in line with everything I said before. We already have data in hand with optical imaging that if we have low accumulation, so this is done with a mice cell that contains a fluorescent tracer as well as a chemotherapeutic drug. Here you see accumulation is low because the blue clouds are not very intense and the tumors are large, right? And then the more you go to the right, the higher the accumulation is, the smaller the tumors are. So, and this is done over 3 weeks, and it shows that the amount of accumulation correlates with therapeutic efficacy. What we also want to do with this formulation, let me go one slide back, this one, is we want to use them to prime the tumor microenvironment. We just, empirically evaluated how does the tumor immune microenvironment look when we treat with free drug versus mice cell drug. We see a quite strong increase in the ratio of M1-like to M2-like macrophages, and that makes them more prone for immunotherapy treatments. And this is in line with a clinical study that was recently published in which people used nanoparticle paclitaxel together with atezolizumab. It's an anti-PD-L1 checkpoint inhibiting antibody, and they got really, really strong enhancement of efficacy in triple-negative breast cancer. And this is probably the most difficult to treat breast cancer. So what we're now trying to do, and this is then, I would say, the last slide before the summary slide, we're trying to implement both things, imaging guidance to do patient selection and immunotherapy promotion into this SPI-cell platform to do metastatic triple-negative breast cancer therapy. And this is a project that we actually started 2 months ago, or actually last month in February, in which we really aim to also bring this platform towards the clinic in the next 3 years. We skip a bunch of slides on priming and just take you to the summary slide. Not because the summary is so important, but because we have a couple of PhD openings. And if you would have any people in your group that might be interested in targeting or imaging, please urge them to send me an email. We have a so-called graduiertenkolleg, which is a research and training group that is focusing on tumor-targeted drug delivery in the broadest sense. Also a lot of imaging involved. And in October, we will have a next cohort of PhD students, 12 PhD students actually starting from October onwards. And we also just started a Marie Curie International Training Network on drug repurposing and nanoformulations, aiming mostly on kidney disease, but also on certain types of other inflammatory disease and cancers. With that, I'd like to stop. I'm not going to read out the summary. Feel free to ask any questions if you would have one. I'd like to thank you for your attention and be happy to take any questions. Thanks.
Thank you, Twan, for the excellent presentation. Very interesting result. I think that there are questions from the audience. They can go by raising their hand or show up anyway. Meanwhile, eventually I may start. I fully agree with the main message you gave about the variability of the EPR. And in order to, let's say, deal with it, and especially nowadays in this new era of personalized medicine, one need really to find a method to assess it. And imaging is, of course, central in this context. Certainly, the EPR is the result of complex phenomena, and therefore one cannot say that one knows once forever, the permeability of the blood vessel in a given region and the perfusion of the tumor area. Years ago, there was a lot of interest in the field of especially MRI to develop a system of different size, of different, let's say, characteristic on their surface in order to, let's say, extract information about also the heterogeneity of the tumor region in this context.
Yeah.
I understand that, of course, to go to the practical side, one needs something that work, in particular, and so for a specific application, and therefore the way to go with a companion diagnostic is probably the way to go, that solve the problem. But I would like to have your comment on what eventually you still see relevant in this context.
Yeah, I think you summarized it quite well. But what we try to do, and what we also do with Crystal Therapeutics together, is to figure out how you can use imaging to do a reasonable level of patient stratification. But there you need to keep in mind that imaging with radioactive means is not very easy and straightforward, right? You need the dedicated equipment, you need the radiochemical facilities, you would have to show the safety also of your companion diagnostic. So it's quite a burden to do it via imaging. But if you work with a nanoparticle that does not have any active targeting ligand, I would not know a much better way to do this in case of a patient with metastasis. Right? Then you probably have to go through imaging to do some level of patient stratification. The other options would be to put nanoparticles not in a monotherapy role, but put them in a supporting role. That's more towards what I said towards the end. If you can use a nanoparticle to activate the immune system, right, then the final outcome depends much less on the total accumulation of your nanoparticle in the tumor. So if the nanoparticle doesn't have to do it alone, it may be good enough to use it without specific tumor targeting. Yet another approach would be if you use the nanoparticle not to target the tumor, but to target peripheral components of the immune system, like dendritic cells in the spleen. These people from BioNTech that are very famous now with the coronavirus, they had a couple of Nature papers on targeting patient-specific antigens, patient-specific RNAs to dendritic cells in the spleen with nanoparticles. So they don't care about tumor accumulation. They just use the nanoparticles to go to the spleen to cross-present the antigens there. That causes an immune response, and that can potentially help to cure the patient. So I think in the very traditional case of nanoparticle-based tumor targeting with chemotherapeutic drugs, not in a combination therapy setting, there's no way around imaging for me. But I'm also realistic and honest enough to say that I feel it's probably too complex to necessarily integrate imaging in these protocols, because only a very limited number of centers in a country can do those types of imaging studies. We did it in the Netherlands together with Guus van Dongen, that you surely know, in Amsterdam. They have the facilities and the knowledge and the know-how to do this, but many other centers don't. So I think we need to find this compromise, right? We realize that imaging is the best way to do this, but we should also think of easier things like biopsy stainings of vessels and macrophages and other things to maybe just at least exclude a certain fraction of patients that is unlikely to respond. I believe that I think the time is now right that people actually started realizing this. This is, I guess, always how technologies develop. Initially everybody was excited about nanoparticles and the EPR effect is in all tumors, right? And now we actually realize that it's much more difficult than we anticipated, and that we need to use, I think also, for instance, DCE MRI. I think it has a lot of potential to be used for imaging or for predicting which patient might respond to nanoparticle therapies or also antibody therapies. But also that has never really kicked in clinically for I would say, for any therapeutic prediction making. I'm not sure what your take on this is, but I think I see a lot of value in multi-parametric MRI to address many of these processes with standard imaging techniques, so then you do not need radiochemistry, but nobody's really doing it. And that's a little bit the problem. You also need money and support. And if you go to investors and you tell them, I have this nanoparticle, it's fantastic, but we need complex imaging to find patients, they would say, oh, well, then find a better way to find patients and then come back. It's this balance that I think we need to figure out how to better address that.
I fully agree that probably we were rather naive years ago to think that nanotechnology, applied to biological system was already, let's say, mature. We are just looking at the top of the iceberg because, the complexity is definitely quite high. But the potential is terrific because one can really cope with a number of biological microenvironment that otherwise could not, come if one go just with the available drugs. I saw that in the chat there is a question from Leila Harabi. Can you show up? We cannot hear you. Or Twan, can you answer eventually,
Yeah, so thanks for the question, Leila. She's asking if we tried anti-VEGF drugs and whether that helps to enhance perfusion. I think it's a really good question. My ERC starting grant was based on this, so to actually figure out whether we can use nanoparticles to enhance perfusion, not via blocking VEGF, but via doing other ways to achieve so-called vascular normalization. I think normalization might be the wrong word, but it's in a way trying to modulate the tumor vasculature for better perfusion. I had a part in this presentation to address this in the broader sense. I skipped through it. So we're trying now to use ultrasound to enhance perfusion of certain blood vessels in tumors. Via imaging, we have realized that multiple blood vessels in the tumor are not properly perfused. Right? We have data. Fabian Kiesling in Aachen did a study on super resolution ultrasound imaging in different types of patients. And when you there look at the fraction of breast cancer patients, you see that only a very small number of their blood vessels that are definitely present are properly perfused. So there's a very low volume of blood flowing actually through those vessels. And that makes it difficult for any therapy to work, right? So the best nanoparticle, the best antibody, the best CAR T cell or other type of immunotherapy will not work if it's not reaching the tumor via the blood flow. So we have to keep into, and with EPR, we always started with permeability. I think we need to make one step back, and that is what Leila is pointing out. We need to understand vessel function towards the tumor. We need to think of enhancing blood flow. One of the PhD students here is working on a project, I think it is quite controversial, but we try to actually enhance angiogenesis in tumors to get more blood flow into the tumor to enhance therapeutic outcome. And people always think this is dangerous. Maybe in certain situations it is. But if you think about pancreatic cancer, there is very, very bad blood flow into a pancreatic tumor. If we can come up with a pharmacological or physical treatment concept in which we can get better perfusion or better or more blood vessels growing into the tumor of a pancreatic lesion, and we do that in combination with chemotherapy or immunotherapy, then overall the outcome might be better, right? It feels maybe initially counterintuitive that we need to go that far, but I think in certain situations, we really underestimated how bad the perfusion of certain tumors is. So it was a very long answer, Leila, to your question. There's a paper from Rakesh Jain in 2014 or 15 in which they used bevacizumab or DC101, which is an anti-VEGF antibody, together with Doxil and Abraxane. So you can look up the paper. People have done this, and they have shown that particularly for the smaller nano drugs, this works. If you would do anti-VEGF at higher doses, what you would get is you would also close these potential gaps that are causing vascular leakiness. And then actually the larger nanoparticles like liposomes do not get out anymore. So this concept has been tested. And for instance, for Abraxane, it was shown that anti-VEGF drugs, they do synergize with nanotherapies. Okay, good.
Yes, thank you. And also very interesting this insight you gave to think to increase the angiogenesis, in a given situation, in order to improve the perfusion and to have the possibility to bring the drug at the disease cells. Because this is actually the real problem.
It's a really big problem.
Reach it. And still also, all the improvement that are announcement in the knowledge of the role of the extracellular matrix, that it can do. And then again, the role of protein that may, let's say, interact with the nanoparticles. And then this, to some extent, eventually favor or, let's say, opposite the target, let's say, task of this nanoparticle. So everything is still, I think, will be a field of huge development in the forthcoming years, and more people will be certainly attracted by studying nanotechnology and, in particular, Theranostics, applications. So by now, I don't see any other question in the chat. So I thank Twan again for this really excellent talk that bring us in this, consider a very important domain of Theranostics, in particularly now with the new view of molecular and personalized medicine. So thank you, Twan. And I think if there are no, let's say, messages from Joanna or Mariana, we may close here. I reconvene all of you to the next seminar, next pub, next Friday, that will be centered on optical imaging. The speaker will be Clemens Lowick from Rotterdam. Thank you very much for all attending this seminar. Thank you, Twan, again. Thank you. Hope to see you soon.